Actually, what happened was after that SARS-CoV-2, in 2022, we all felt that, this will be the end of COVID-2. But then there would be only some super sporadic infections here and there somewhere. But unfortunately, we have had another surge of infections, mostly viral, in different parts of our country. So I remember in the year 2022, we had hand-foot mouth disease somewhere in July and August. Then we had respiratory syncytial virus. Then we had measles outbreak, I remember, in Maharashtra. And then we had adenovirus. And then now we have also H3N2. So we have also heard the new strain of COVID, which is coming up, though it's not that troublesome. So with all that, there has been a lot of confusion. And, our colleagues would like to know whether, in a given child, whether this is a bacterial infection or viral. If it is viral, then which is the virus? Is it rhinovirus, adenovirus, influenza virus, COVID virus? Because I always jokingly say that even Rajnikant cannot identify which is the virus producing fever, cold, and cough. So if at all it is viral, then is there something which we can do? For example, whether I can start oseltamivir upfront to play safe in a given child. So there are many questions in our mind. And recently I had one small little girl in the OPD, about 7-year-old, and she was playing with the doll. And when I was examining this small little girl, she was talking to her doll, don't worry, it is viral, it is viral. So even small little children have picked up the word viral. But now when somebody says it's viral, I also get panicky, because any virus can, turn into any form, and then it can create problem. So after this COVID period, that means a major COVID pandemic period, there have been waves of different viruses. And in my experience, even older children are getting affected. There are children who are coming to us with recurrent respiratory infections, back-to-back viral infections. And the frequency of these viral infections is more. And there are children with otitis media, children with adenoidal hypertrophy, who come to us with snoring and mouth breathing. And as I told you, there has been a surge in influenza. Usually we witness influenza in monsoon or post-monsoon, but now we have unseasonal surge in March and April. And then that adenovirus, which we never discussed so much till now. Actually, I say adenovirus has become a bad adenovirus. Okay, it has become really bad. It is showing varied presentations, and it is producing a prolonged illness. And, our teacher used to ask me, Pramod, tell me which is the respiratory virus which produces non-respiratory presentations. And of course, the answer he expected was adenovirus. Okay. And the CBC and the CRP also, which we once thought that it's already because of bacterial, but it's not so. Even in adenovirus, we have high CRP. And that's why, everything leads to the dilemma about therapy with antibiotics and the antivirals and so on and so forth. So it is necessary that we have clear concept of dealing with the viral infections when it comes to the OPD setting. And that is why today's discussion is very important. Usually these topics are not discussed in the medical platforms, but now we have Dr. Bhaskar Shenoy, who would enlighten us more about these various viruses, and then we can have your questions after the presentation is over. So Bhaskar, you can start with your presentation. Thank you.
Thank you, sir. Thank you, Sureka and the team for giving us an opportunity and the nice introduction. Thank you, Dr. Jog, as you have been always nice to me, as always. So thank you so much for this opportunity and reposing faith on me to deliver this lecture. So having said that, let me share the screen. Yeah. So today I'm going to talk about current surge in respiratory infections. As Dr. Jog has already given the brief introduction, there has been an unusual increase in the number of respiratory infections. There has been unusual increase in the way the respiratory viruses manifest, and the unusual seasonality of the virus and unusual manifestations of the virus. These have been some special features of the current surge. So I will be talking about a few viruses, not all the viruses which Dr. Jog has told. The surge in respiratory infection, as we told, it has been recorded not only across the country, but across the world. Even the developed countries and the developed countries have seen this pattern of increase in the infections. The H3N2 variant, the COVID variant, the respiratory syncytial virus, the adenovirus, enterovirus, measles virus, these are responsible for the surge. The influenza virus, which has been doing rounds every year, this year again it has come with a little different form. Like the COVID virus, it is known to spread via respiratory droplets. And apart from that, the other H1N1 variant also has been recorded. Not only H3N2 variant, the H1N1 variant also has been seen. So this viral surge may be due to the lack of immunity or the reduction in the immunity of the susceptible population. Always we know that the viruses are likely to have drifts and shifts in their antigenic content, and especially the H1N1 or this flu virus is notoriously known for shifts and drifts. So we have been seeing that all these years, the winter months, normally we have increased respiratory infections. That is because, especially in the Western countries, they spend more time indoors because the winter will be so bad that they don't go out. And the dry weather, the cold dry weather allows the virus to survive and replicate. And with the more congregation, the likelihood of infecting others is very easy. But the last two winters, that is 2021, were a little different because the people never had respiratory infections. The COVID was taking the dominance. The public health restrictions which were put during the pandemic also have been the reason for not having the other viral infection, because they are also spread by the droplets. But these restrictions have been lifted in the recent months. The long period without infection have affected the individual's immune system. That means for endemic infections, the number of cases of infections are generally driven by the rate at which the people lose their immunity. That means longer the people are not exposed to infection, the weaker their immune system becomes to prevent the infection. What I mean to say is, frequently small infections, if they keep on getting, the immune system always is trained to fight that infection. Whereas when there is not much frequent infections, the immune system also, in a way, forgets to fight this infection. So some of the countries are seeing not only increased rate, but the severity also has increased. That is another reason. If the people are not exposed to the pathogens for a long time, the mucosal immunity begins to wane, and that is responsible for increased severity, increased frequency of these respiratory infections. The question comes how the respiratory virus will respond to the new immune landscape. That is unclear, and the pattern of viruses in different countries is different. The new dynamics of respiratory infections will require an improved understanding of the circulatory patterns that has been altered in the post-COVID-19 pandemic. So there was a beautiful article in Lancet Respiratory Infections. The COVID-19 pandemic disturbs the respiratory virus dynamics. That clearly says how the dynamics of these viruses have changed. So longer the period of this, it is likely that the systemic immunity to infection also diminishes. That means they become severely ill when they are infected. So why this surge? The other reason is that the last 2 years we were used to living in the very ideal environment, that is sanitized environment, and we were not exposed to the infection. So there has been what is called as a immunity gap, and that has contributed to the severity of the infection. Now that the schools, social gatherings have opened up. That has contributed to the increased spread. Has COVID-19 contributed to increase in the other viruses? So the jump in respiratory virus is related to the dramatic change in the community behavior. These behavior were restricted before. Now that the exposure allows the children to develop natural immunity to common respiratory infections, especially RSV, and sometimes these can be severe. So with this brief introduction, I'll be talking about only few common viral infections, respiratory viral infections that we have seen in the previous few months. That is adenovirus, respiratory syncytial virus, influenza of H3N2 variant, and COVID variant, that is XBB.1.1.6. So let me take through some real scenario cases. This is one child who had 5 years old, had fever of 7 days, moderate to high degree, and it was diagnosed as initially in one of the other hospitals. They did the swab, then the diagnosed as influenza A, started on Fluir. The fever came down for 2 days. Then again, he had a spike of fever, and 7 days before he came to us. Then he had also cough and cold. He was febrile and looking toxic, but otherwise he was okay. His counts were okay with the hemoglobin. Only the CRP was quite high. Platelets were okay, and cultures didn't yield anything. But we had sent, because that was the time when the lot of infections were there, respiratory viruses were there. So we sent the respiratory panel. So that showed that the adenovirus was detected. So this is a adenoviral infection. If you look at this case, as Dr. Jog told, this had a little prolonged than the typical viral infections. Typical viral infections, we say 3, 4, 5 days it should go. But here it went on up to 10 days. Even after admission, he had fever for 10 days. The adenoviral infection goes on for a little longer time. And the CRP, we generally say the viral infection, the CRP is less. But adenovirus is one infection where the CRP is likely to be quite higher. And we have seen some adenoviral infections where the CRPs were more than hundreds also. So this child was treated with the supportive care. He improved and then discharged. So what is this adenovirus? These adenoviruses are medium-sized, non-enveloped, double-stranded DNA viruses. They have a common complement-fixing antigen, and they infect the human and the animals as well. They appear like this. This is like a space vehicle. That is how the adenovirus is described. It was first described in 1935, and now based on the genetic workup, they have identified around more than 50 serotypes, and overall it is responsible for about 10% of the respiratory infections in children. There are other types, but all the 52 types are not important for the human pathogenicity. There are some particular serotypes called particular illnesses. For example, serotype 3, 4, 7, 14 are responsible for the respiratory illnesses. 8, 19, 37, 53, 54 are for epidemic keratoconjunctivitis, 40 and 41 for gastroenteritis. In India, there was one study done in Calcutta where they reported that the 2, 3, 4, 6, 7, 8 and that 37 were the common serotypes in this part of the globe. It can cause, as Dr. Jog told, not only respiratory infection, it can cause infections of the eye, urinary bladder, intestines, and so on. This is briefly the various infections that this virus can cause and the serotypes responsible for the individual infections. So clinical features I have already told. In the respiratory infection, it can affect the upper respiratory and the lower respiratory also. It is, as I told, 5 to 10% of the thing, but it is little less in the adults. The respiratory infections can be of 4 types. One is acute febrile pharyngitis. causes only the pharyngitis with cough, fever, and sore throat. There is one more, what is called as a pharyngoconjunctival fever. That is called as epidemic pharyngoconjunctivitis. This is occurring in an outbreak, and usually in the children's summer camps or in the schools, or when they go for swimming pools. That is called as swimming pool conjunctivitis. And this season, we have seen a lot of children with this kind of conjunctivitis with pharyngoconjunctival fevers. The acute respiratory disease also sometimes can be epidemic, and some cases this has caused pneumonias also, both in children and in adults. And the pneumonia by adenovirus is more common in those with compromised children. The pharyngitis, as I told, 1 to 7 is more common. Pneumonia 3, 7 are common, but 7 type is known to cause even a fatal pneumonia in young infants. The acute respiratory disease usually in crowded places, and initially they described more in the military recruits, the military camps, they said, and then 4-7-21 were responsible, and conjunctival pharyngitis with conjunctivitis 3-4-14. This is one, the epidemic keratoconjunctivitis. As I told, some cases we have seen the granular conjunctivitis. When you see the conjunctiva, palpebral conjunctiva, that shows some granular formations. That is called as, that is seen in epidemic keratoconjunctivitis. And this is another case where in a child, wherein the chemosis and very severe erythema of the conjunctiva, both bulbar and the palpebral conjunctiva, you can see. And this is another thing wherein sometimes actually something like a subconjunctival bleed they can have, and such severe conjunctivitis we have seen in the last epidemic. So diarrhea also sometimes it can be caused, and hemorrhagic cystitis is one thing which some children have developed. They just develop sometimes dysuria, sometimes painless hematuria. You do the culture, no growth, and some ultrasound shows some cystitis features, and it is invariably due to the adenovirus. Mesenteric adenitis, intestinal, intussusception have been seen. As I told, the immunocompromised children are more susceptible for severe complication. So the diagnosis mainly the clinical, the child with an epidemic going on around, the child with the high fever with a little prolonged course, the child with the conjunctivitis, pharyngitis. These are responsible for the these are the clinical points that takes us towards adenoviral infection. The antigen detection, PCR, viral isolation, serology, all these things can be done. But the only thing is the isolation and other things are not done routinely in the labs. The PCR is one thing which can be done either in the nasal sample, and ELISA generally we do in the stool samples, especially rota and adeno, the combo comes in the stool. Sometimes the stool combo contains 5 other viruses, so that can be done. So in the stool, we can use the ELISA method, but in the respiratory nasopharyngeal aspirates, you can do the PCR method. The BioFire or the multiplex PCR can be done. So the treatment largely is supportive, like any other viral. Even the conjunctivitis do not need any antibiotic drops, because I have seen the antibiotic drops have been used right and left. And other thing is that we should not give aspirin, and hospitalization only for those with the complications, not needed routinely. Some conditions we use the drugs. It is not for a general practice. In some severe immunocompromised children who have disseminated adenoviral infections, we use cidofovir, which is not widely used, but it is costly also, routinely not used, only in disseminated infection in a immunocompromised child. Ribavirin, Vancyclovir have been tried, but no much benefits. Brincidofovir is another ester of the cidofovir with the lesser renal toxicity. This is being tested, and in a severe case, they tried even the immunotherapy, whereas lymphocyte infusion, the donor lymphocyte infusion and derived adenovirus specific T cells, and these are used in those patients who are not responding to the conventional therapy. The adenovirus was in the headlines during the COVID season because the adenovirus was used as a vector to produce some of the vaccines against COVID. So now, this is all about the adenovirus. But what is happened in India? What was the scenario of adenoviral infections in this season? As West Bengal, especially Kolkata, was the one state where there is a huge surge of the respiratory, the adenoviral infections since January. And the official records say that more than 12,000 cases and at least 20 deaths, but unofficially they say the death rate has been more than double of this number. There are other states like Assam, Maharashtra, even Karnataka has seen many of these, maybe a milder variety, but the death and the complications, the admissions, hospitalizations have been more in West Bengal. And they did during that epidemic, the serotyping was done by ICMR, and they found that the adenovirus type 7 and 3 were responsible for the current surge of the infections. And that study also found that the adenovirus 7 was more actively can spread and can replicate. It can grow more actively, and that is known to produce more severe cytokine response, and that is responsible for the severe disease. And conversely, they found that in this epidemic, adenovirus 7 was the culprit, and that's why the cytokine response was more, the complications was more, and the severity was more. It is not that adenovirus infection came and went, something like COVID, where we get long COVID or post-COVID complications. Even in adenovirus, they had something recurrent problems or the long COVID problems, something like long adeno problems. So those who have recovered from adenovirus infection, they came back with some complication. One important complication, especially in West Bengal, they have seen is post-infectious bronchiolitis obstrucans, that is PIBO or popcorn lungs, what they call. So this is a quite severe and problem which has to be tackled. The post-infectious bronchiolitis obliterans has been one of the complications for their readmissions. It usually develops after few weeks of recovery from the virus, and this has been found in those children who received oxygen support for a longer time, those children who were on mechanical ventilations, and this group of children had this post-infectious bronchiolitis obstrucans as a complication. This is one case which I thought I will share with you, which is a severe community-acquired, adenovirus, community-acquired pneumonia in a immunocompetent child. This is a 4-year-old child with a 3-day history of fever and typical respiratory symptoms, the dry cough, sore throat, and 3 days prior, 1 day prior admission had some erythematous rash, and then he was febrile, BP was okay. Then saturation was 94 in room air. There were macular rashes, widespread, some petechial spots, and the oropharynx was erythematous. Labs, the WBC was 9,200, platelet of 2.54 lakhs. CRP was quite high. You can see the 169 milligram. Liver enzymes were okay. CPK was raised, and immunoglobulin and chest X-ray was remarkable. Unremarkable. He was started on antibiotic as per the protocol. After 24 hours, he was on ceftriaxone. He deteriorated rapidly than what is expected of his illness, because the X-ray was not bad, and he went into acute respiratory failure and hypotension, ventilated, and vasopressor support was given, and he was added on oseltamivir with the hiking of the antibiotics also. The chest X-ray showed interstitial infiltrates bilaterally. The X-ray, which was normal in the first X-ray, showed bilateral infiltrations. All the cultures and PCR for Streptococcus pneumoniae was negative, and then nasopharyngeal aspirates were sent for respiratory panel, influenza, RSV, were negative, but it was positive for adenoviral. So the subsequent sequencing was done that found to be serotype 4, but thankfully he made an uneventful recovery. So this is a case of a severe adenovirus pneumonia in a child with immunocompetence. Though we say the complications are more in the compromised child, this is one case where immunocompetent. That's why we did some immunoglobulin and immunological studies also. The next virus which we saw was the RSV. As we know, it is a virus which every year we see, especially in a child below 1 year, sometimes below 2 years. Around 6 months to 12 months is the majority. They come with the sudden onset of wheezing, cough, some URI, and then not much of fever. The global burden has been more, and then the long-term effect of this RSV infection is that these children were known to have recurrent wheeze-associated lower respiratory infections or bronchial asthma-like thing at a later life. So there were some risk factors, especially the exposure to smoking, young age, and underlying disorders like chronic lung disease, chronic heart disease. All those things are risk factors for developing RSV. So the URI, pneumonia, wheeze-associated respiratory infection, exacerbation of asthma, viral pneumonia, viral-induced wheeze. These were some terminologies used in describing various manifestations of RSV. Meta-analysis of 9 studies involving 4,000 children, wherein they used PCR to find out which virus. They found that the RSV was responsible for about 11% of the community-acquired pneumonia cases. Now the question comes, having said that, is the routine testing of the respiratory virus is useful? The problem is that the multiplex PCR, if you try to do, it is very costly. One thing is, it will help to identify exactly what is the bug that is causing the problem, but that will not change the treatment modality, because most of the viral infections you give supportive medications only. And one thing is that it helps in differentiating from bacterial to viral. Thereby, the antibiotic stewardship can be more appropriately done. So the other situation wherein this testing may be useful is, you don't have, you are in a dilemma whether it is a bacterial or infection or viral, because one of these studies, it highlighted that about nearly 1 to 2% of the children who had viral infection had bacterial infection also. That means the co-infection of viral and bacterial also was seen. But the NICE and AAP guidelines do not recommend routine testing of the nasopharyngeal swab for the respiratory pathogens. Routine investigations are of no use unless you have some complications. The management is just a symptomatic oxygen, oxygen, oxygen. People have no antibiotics, no steroids. Bronchodilators do not work. Leukotriene inhibitor do not work. Only thing is maybe hypertonic saline works, and some cases nebulized epinephrine in some cases, but otherwise most of them have no much data on that. Ribavirin is one thing in in the children, infants with bronchiolitis, but Cochrane review it suggested that it is not clinically effective at treating the RSV bronchiolitis. So the inhaled form of this is also found to be useful, but it is very costly. As I told, the wholesale price for single day treatment is $29,000 in the US. Imagine, is it affordable? So some severe cases, recalcitrant, you have done everything, you have proved that it is the RSV, and such cases, but still it is not responding, becoming very worse. That can be a very small number of patients. The IVIG, either general IVIG or the RSV specific IVIGs, if available, can be of some use in some children. Next, the other virus which we want to look at is the COVID virus, which is COVID variant XBB.1.16, which is called as Arcturus. Arcturus also has been behind the current surge, though in India more than 10,000 cases are reported, and the importance is that this particular virus shows immune escape and able to evade immune system, even because of the infection or because of the vaccination, whatever immunity you have got, this variant is known to evade this. And this is a combination of two, BA.2.10.1 and BA.2.75, and other mutations were responsible for. But one good thing is that there has been no increased hospitalization, increased complications or deaths because of this mutation. And there have been no laboratory markers on the disease severity for this mutation. This is highly transmissible with a high infectivity rate, and it is likely to escape the hybrid immunity. Hybrid immunity means the immunity developed by natural infection and immunity developed by vaccination. So this is likely to evade that. That is one specialty. In Pune, the BJ Medical College and Sassoon General Hospital, they conducted a genomic sequence for this when the initially this resurgence was seen, and they found that out of the 67 samples of genomic sequencing, 27 were XBB.1.16 variant. And one more study, they found that out of 23, out of 56, 23 were of this variant. That means about more than 50% of the samples were belonging to this. The clinical features, like any other viral infections with fever or respiratory infections, respiratory signs. But one thing in this particular season, they found that the infantile phenotype has been found to be more, and infants with the high fever, cough, cold, itchy conjunctivitis, which was not seen in earlier waves. And this particular season, some centers, especially MP and Delhi and some other states, they were reported more of conjunctivitis without stickiness, non-purulent conjunctivitis during this particular season. So what makes it risky? Risky in the sense it is highly contagious, but luckily the complications are less. As I told, the hospitalization is less, and it will escape the hybrid immunity. The two viruses can be infected simultaneously. There are some cases wherein the two viruses also can be seen in the same individual. The co-infections, once it occurs, it tends to be more severe. I mean, the pathogenesis is that different viruses act on different receptors and different mechanism of respiratory damage, and that is responsible for worsening of the problem. The last virus which I'm going to talk about is the influenza virus. The influenza virus also, as we know, it can be more severe in the immunocompromised than the immunocompetent child. There is no particular treatment. This is the particular season we have found that the H3N2 variant is more responsible for that, and H3N2 outbreak was seen last few months back. Maybe the reasons they put, in addition to what I told in the introductory part, the low vaccination rates and heavy air pollution has been found to be associated with the worsening effect of the influenza. The H3N2, I will not go into the details of that, but the only thing is sometimes it can cause complications. This particular picture shows all the clinical features of the influenza. The treatment, as we know, no specific treatment, only symptomatic treatment. And even antivirals are not recommended routinely for all patients. Most of them recover because by using for every child, we may contribute to the antiviral resistance, something like antibiotic resistance, antiviral resistance, because in the armamentarium of viral infection, we have only few molecules compared to antibiotics. We don't have much antivirals which are used in the office practice. And if the virus gets resistant to these also, we are left with no antibiotics and antivirals, and consequences are more. So the challenge of getting the right diagnosis with all these viruses, when the child comes to you with the respiratory infection, always you have the dilemma. Is it a common cold which generally comes? Is it a seasonal flu, H1N1 or H3N2? Or is it a COVID variant that is this particular table clearly, I mean, helps you in grossly to classify or stratify the individual things. A common cold, any virus, mostly rhinovirus. Flu is by influenza and SARS-CoV by COVID-19. In a common cold, the onset of symptom is gradual. Headache is not very common. Usually cough will be there, body ache will be there, sneezing, sore throat. Whereas in flu also, they can have these symptoms. So, and the fever, diarrhea, then nausea, vomiting, shortness of breath. Shortness of breath and difficulty, usually due to the nasal block in the common cold, but in H1N1, flu or COVID, it can happen. So comparison of which virus is deadlier, that is the other question is, given a choice, will you choose H1N1 or H3N2 or COVID-19 mutant virus? So when you compare the mortality rates, the death rate with the H3N2 has been around 0.4%, whereas COVID 1 to 2%. It all depends on the geographical underlying causes and the effectiveness and the starting of treatment and the management protocols, etc. Is this variant dangerous? So it has not caused any problem. Only those people who were at risk, the elderly people, very young children, pregnant, and those with underlying medical problems are more. Testing is generally not required. So I have, in brief, I have told what is the dynamics of respiratory infections in post-COVID area, COVID and post-COVID season. What are the common respiratory infections that happened during this season? And How do we differentiate between these two? And some cases wherein you can just probably most of you must have gone through these cases, and some differences in the presentations. For example, the COVID variant with the conjunctivitis, which was mimicking adenovirus, and such cases we have to do the test. So thank you so much for the patient listening. Thank you for the opportunity given. Thank you, sir.
Thank you. Thank you, Bhaskar, for that excellent presentation. And I'm glad that you gave the information about those viruses quite in details. Because many times, we keep discussing about these viruses, but our listeners always would like to have more and more information, because on a Sunday afternoon at 4 p.m., those who are watching, they must be the real scholars who are probably watching. Anyway, we have some questions from the listeners. So one of our listeners wants to know that when a child comes to us in the OPD these days for fever, and if the fever is going on for almost 5 days, and the onset has been typically like a viral fever with cold, cough, and headache and muscle pain and all, but the fever is still not going on day 5, and the child has been put on amoxicillin from day 3, and now on day 5 the child has come to us. What do we do at this stage? Do we don't have the facility for the nasopharyngeal swab, so at this juncture he wants to know whether we should admit the child, whether we should put the child on oseltamivir. So what will be the rational treatment in the background of these viral infections going on?
Sir, at least see, this is particularly, we have to rule out other bacterial infection like enteric fever or other things. So get one X-ray, get the blood culture, get the routine counts. Look at the CRP also. And the child's clinical condition, if it improve, I mean, stable, if the child is okay, not very sick, then probably we can buy some time in getting into a diagnosis. And at least the H1, if the child has respiratory symptoms, you can get a swab, at least for H1N1. You may not have the multiplex PCR available in all places, and affordability is also a problem. But at least for the rule out H1N1 or H3N2, because that is one treatable cause. If it is so, and if the child is persistent fever, you can treat it. But if the child is clinically stable, and if the child do not have other severe respiratory symptoms or signs, blindly, if the child is immunocompetent, blindly starting oseltamivir is not advocated.
Okay, so if I get you right, in a child who is worsening or who is developing or increase in the respiratory rate or distress, then we can think of putting on oseltamivir.
Empirically. Empirically is not for all the children.
Right.
Only when you have ruled out other causes, only if the child is in worsening and the clinical picture matches with the severe H1.
Yeah, then only we should put him on oseltamivir. And then one of our colleagues wants to know whether oseltamivir started later in the course of the illness is of any help, because usually, we have heard that in the initial 48 hours, if you start oseltamivir, it works better. So is it that after 5 days, it will help to some extent?
See, generally, as you told rightly, in the initial period, helps definitely, and it helps to prevent the spread of the virus also. That's the other advantage of that. Having said that, if the child presents you with the late and you have a the proof, then you can start any time. Whatever benefit it gives, let it give. And the benefit may not be as good as what was there. I mean, if it is started early, but if the child is sick, if the child is ill, nothing prevents you from starting.
Okay. And then one of our listeners wants to know as to what are the fallacies of nasopharyngeal swab, if at all we have the facility. Are there any fallacies?
Yeah, definitely. It's a very good practical question, especially the multiplex PCR. When you multiplex a PCR, when you do, especially in the nasopharyngeal this thing, sometimes we get multiple organisms, one or two organisms. It can be H1N1 along with the rhinovirus or Streptococcus pneumoniae, one bacteria and virus, or two viruses, something like that. Most often, we may have to have the underlying clinical condition. If it correlates, then probably we have to take it with the positive thing. Because, and in a respiratory sample, it is the nasopharyngeal aspirates in a pneumonia is not a good sample. If you can get a BAL sample or the lower respiratory sample, wherever the facility, that is a good sample. But when having said that, it is not practical every time. But if it is done, that is a better sample in a respiratory. This can be, some of the viruses can be commensals also. Viruses or bacteria can be commensals. And we don't have a method to differentiate whether it is a pathogenic or commensal.
That's very good. So we can have these viruses like rhinovirus and enteroviruses as commensals. But if I'm right, pneumococcus and Hib, they are also supposed to be commensals. They are not the pathogens, isn't it? Yeah, that's fine. And one last question from one of the listeners is that in a child on day 5 of fever, if nasopharyngeal swab has come positive for influenza A, and already this child has been on amoxicillin, then shall we withdraw amoxicillin or whether we continue antiviral as well as antibiotic?
The child, it all depends on the clinical acumen and the clinical condition. These are the two things which I will tell. If the child's condition is, the clinical picture is like a viral, child has improved, child is on oseltamivir, showed improvement, you continue, and if the other counts and other collaboratory findings say that it is viral, you have to boldly withdraw the antibiotic. On the other hand, if you have some pneumonia, because in pneumonia or the lower respiratory infection, it is very difficult to differentiate between a bacterial and viral, and in such cases, you can continue. Having said that, co-infections are known to occur and complicate Streptococcus pneumonia as a complication of flu virus is well known. They can have pneumonia as a complication of flu.
Right. Yeah, I also remember to have read that almost 25% of the cases of pneumonia have co-infection. Yeah. So, as you say, rightly, it's the individual assessment in that particular child. And if you have the esophageal swab report, of course, I would say, Bhaskar, at least if we have the report, we should not escalate the antibiotics. Yes. If at all it is viral, either you should maintain at amoxicillin or amoxiclav, whatever has been started, but rather don't go to vancomycin and others. So yes. At least that's also probably a part of antibiotic stewardship, isn't it? Right. So I think you have answered all these questions satisfactorily. And I must say that fever, cough, and cold, the symptoms remain the same. And watch the child carefully for lower respiratory tract involvement. Don't run after finding out what is the virus. Though Bhaskar has described all the viruses, don't try to split the hairs whether it is adenovirus or this. Watch the child, and I would say treat the child and not the report, isn't it? Because when you are examining the child, and mostly I can say that these are all garden variety typical presentations of majority of the cases, unless they are having co-infections or secondary bacterial infections, and they would mostly settle in 5 days, except the adenovirus, which is taking little long. And maybe in my experience, less than 2 or 3% require admission. And the sicker ones, they are getting admitted, and they are the ones where we need to test the nasopharyngeal swab for diagnosis. And of course, one has to be very careful as to whether the child is developing super infection or no. Bhaskar, any other final comment?
No, especially when the child has a prolonged fever, and which was a little unusual for a viral. Right. So we had many cases of such, wherein the fever persisted. We did all the possible investigation to rule out the infections. Everything came negative. And such children, when I with some respiratory, and the other pointer is the conjunctivitis. The child comes to you with a very severe conjunctival inflammation, and sometimes the palpebral conjunctiva may be granular conjunctivitis, or the subconjunctival suffusion is so much. The other thing is that we need to differentiate such cases from Kawasaki disease. The adenovirus is a close differential diagnosis for Kawasaki. So in such cases, we need to keep in mind the Kawasaki also. But the Kawasaki, the conjunctivitis is very typical. It is non-purulent and it spares the limbus. So that is one important thing. And it is bilaterally equal. Whereas adeno, one eye it may be very severe, one eye it may not be that severe, and the conjunctival suffusion is very common. And other features, of course, even in Kawasaki, you may not get other symptoms, symptoms and signs. There may not be rashes, there may not be lymph node, but the child may have only fever and eye changes. So say that can occur even in adenovirus. So the literature and the practice says that adenoviral infection is a close differential diagnosis for Kawasaki.
Yeah. With that, I think we have all the information, most of the information on viruses. Of course, it goes without saying that the preventive measures for these different viruses are plenty. We all know about the sanitization and the use of mask and keeping the social distance and coughing in the elbow and following all those precautions related to hand, like avoiding the handshake and using the handkerchief and washing the hands and keeping a person at hands distance and so on. And finally, we all know that avoiding the handshake means saying namaste. So with that, with folded hands, say namaste to avoid the transmission of the virus also. Of course, in a webinar, we cannot transmit any virus from anybody.
Remote transmission.
Remote transmission. Anyway, so with that, I think it was an excellent session. And Surekha, if you have any other comments or any announcements, please go ahead. You have to unmute. Surekha, you have to unmute your.
Thank you so much, sir. It was another wonderful session, Dr. Bhaskar Shina. Thank you so much, and it was great to have you, sir. Thank you so much, Dr. Pramod Jog, for moderating again one more webinar in a really great way. And thank you all the participated doctors. I would like to thank from bottom of my heart that you had presented on Sunday evening. Thank you for spending your valuable time with us. So let's look forward for next series. We'll update you shortly the topic and the timing and date for the next series of Pediatrician Pathshala Volume 2. Thank you, everyone. It was great to have you.
Thank you.
Thank you. Okay. Bye, Surekha. Bye, Dr.
Thank you, sir. Thank you, both of you.